is not getting proper teaching or proper training. That was the idea behind it. I know the difficulty of students, so I have started this class on that basis. So I think it is quite successful, and I will ask Ajay to start his class. Dr. Ajay, please.
Message, and through you, I want to convey all the stalwarts of API, the top notches of API who have done a great job in educating the mass. And this is going to be a very good program. Soon we are going to have exam as suggested by Dr. Tiwari. He has asked me to set 50 questions, which we will do, and then whenever he thinks desirous, he will fix up a date for exam. And then all these topics will be collected in a book-like thing, which Dr. Tiwari, whatever he thinks, possibly in coming API and all, he can come out with a compendium of all the talks done so far in various aspects, not only cardiology. So that will be a great thing. So thank you, sir. Thank you very much. Let me share my slides. So are you able to see my slides?
Yes, it is very well.
Yeah. So my first message would be greetings from the API Dean Short Course Certification course, and I invite everyone, each of one of you, to participate in this program and put your questions and comments. And you can comment also. You can give your opinion about a particular topic or a particular subject. So, so my topic would be something different today. It will be from intervention to prevention in cardiology. So let me begin with these slides. I like this. I've been presenting this slide quite often. That exercise is the vaccine for heart. And this was a API program at Bhagalpur. You can see that a police officer and Dr. D.P. Singh, everybody ran for health, and this was a kind of cyclothon done in APCon 23. So the message is that exercise is a real vaccine for the heart. It can prevent heart disease. So all of us must exercise. With this message, my second thing would be like this slide. I was just reading few important things. That what are the drugs which FDA has approved to stop aging, and these are the 4 drugs like metformin, like GLP-1 antagonist, and then we have statins, and we have one drug which is used for osteoporosis that is also thought to prevent aging. So that's a very important message, that we are in a stage where we are in a position to not only improve the health condition, the cardiac health condition, but also we are trying to, we are inching towards extending our ages. Second message I wanted to give is, as far as preventive cardiology or preventive health is concerned, is that aging is an inflammatory process. That is a recent concept which has come. And so by stopping inflammation, we can probably prevent cardiovascular disease. And there are a lot of work going on in this field. And you must have seen that colchicine and drug like imitinab, these are the molecules which are thought to prevent canakinumab. There are so many drugs now which has come, and they are, in fact, they are coming in the guidelines also. that these drugs can prevent atherosclerotic process anywhere, including heart. So with this, I go to switch over to ECG, which is very, very interesting. All of you know what this ECG is. This ECG is of hyperacute acute MI. You can see ST elevation, sky high ST elevation, and this is a very bad sign. And this would indicate that probably heart is jeopardized and there is a severe transmyocardial ischemia. And there, you have to act fast and do something to be thought to a modern temple of cardiology, where all the procedures are done. We keep on doing all these procedures, and this is where all the procedures are done, right from diagnostic cath angiogram to interventions. And so these days, in our country, maybe about around 1,000 cath labs all over the country. The city which I belong to, Patna, has got about 25 plus cath labs. So that's very important that cath labs have given us a lot of help, that helped us to do diagnostics as well as therapeutics, and all this procedure like angioplasties, primary angioplasties, various newer techniques like apart from pacemaker, CRT devices, left bundle area pacing, and so many procedures are now being done. And one thing is now EP lab is also added to the cath lab, electrophysiology. So we can study the various electrical findings of heart, and then we can evaluate and decide about doing ablation, cath lab, electro EP ablation to cure cardiac arrhythmias like supraventricular tachycardia, atrial fibrillation, even ventricular tachycardias. So this is a new area which has developed inside the cath lab. So what is the rationalism of acute MI management? Rationalism is early reperfusion, and we know that time and again we have said that time is muscle, and aim is to prevent death, limit the extent of myocardial damage, and establish myocardial reperfusion. So mechanically, this is done by primary PCI or primary percutaneous coronary interventions. Pharmacologically, we all know that this is done by thrombolysis. And third area, which is area is pharmacoinvasive approach. That is a combination of pharmacological and mechanical intervention. You reperfuse, you give thrombolytic agent, as you can see in this patient, thrombolytic agent being given at the site of, at home or maybe in the ambulance. This is a concept which is coming up now, that diagnosis should be confirmed, ST elevation MI, and give thrombolytic agent, and then shift the patient to the nearest lab. So, but sadly enough, it is said that to a man with hammer, all nails look through, they need pounding. So the lesion is the mission is stenting. So that's what Mark Twain said. And this is true with modern intervention cardiology, and that is not always true. Many a times, you must have heard that stenting is done in a borderline lesion, and something which is not accepted and something which is to be criticized and We have to be very, very careful, and there are many areas which have developed, like uh, seeing the physiology of that obstruction by doing FFR, and seeing the anatomy by doing IVUS, that is intravascular ultrasound. So again, I will give you an example of acute ST elevation MI, old man who came to us long time back, 2005. This is and then he was thrombolized, and post thrombolysis you can see that the ST is settled down. ST has come down. So that is what happens. The pain disappears, ST comes down, and you can have reperfusion arrhythmias. So these are the three criteria of knowing whether you are successful or not. So thrombolysis is a very important modality of management of acute ST elevation MI in peripheral setup. And this is another example of one of my staff who had 38-year-old female. She had acute inferior MI in my clinic, and she said she cannot go anywhere. Whatever you want to do, do it here. We got a tenecteplase from the nearby chemist and gave it, and see that pain disappeared, and this ECG looks like absolutely normal. If this ECG is given to you, you cannot recognize that she had ever MI, and she did not undergo because of lack of money and financial constraint. She could not undergo angiogram or angioplasty or anything like that. So my message is that thrombolysis is still a method of choice in peripheral setup, in district towns, in blocks, in villages, where you don't have facility of primary angioplasty or angioplasty. But this is known as a pharmaco-invasive strategy, and it is said that if you do thrombolysis in first 1 hour, you can about myocardial infarction happening. I mean, this is known as aborted myocardial infarction, and this is a very important concept which came long time back in India also, because of many limitations and traffic condition and delay in transportation of the patient. This is one of the most sought after strategy, pharmaco-invasive strategy. So somebody asks you, what is the best strategy for India? The best strategy for India is pharmaco-invasive. And there has been a lot of studies, there have been a lot of papers from South published in Indian Journal and other places about pharmaco-invasive strategy. Even in USA, where I am right now, reperfusion therapy for STEMI is still quite a bit of pharmaco-invasive approach, despite so much of development. Then I'll show you this. This is a picture of what? This is a picture of renal denervation being done. So renal denervation is a modality to treat severe refractory hypertension, wherein you go inside the renal artery and you give radio frequency energy, you ablate the nerve plexus, and this causes fall of blood pressure. This is a new modality which has come up, but this is the truth. Now in our country also, there are several centers which are being done, which are having this facility. Not very difficult procedure. So, but how common is hypertension? Hypertension is such a common disease that, if you say in our country, out of 3 adult population is having hypertension. And, some certain countries like Croatia and all in Europe, they are having, 50% population which are hypertensive. This is a very sad situation. And in USA also, you can see the 67 million people, maybe more. So high blood pressure contributes to about 1,000 deaths per day. So only by controlling blood pressure, you can decrease the misery of cardiovascular problems, including acute myocardial infarction, stroke, and so on and so forth. So hypertension is a global problem. The concept is that we start with 2 drugs at least. So dual drug is a must. Never start with the single pill, 2 drugs, and there are several newer molecules which have come up in hypertension. Now people have started using SGLT2 inhibitors, and even ERNI is being used for is being tried for severe refractory hypertension. There are several studies, including studies from China, that shows that ERNI can be of great use apart from MR antagonists, especially the non-steroidal MR antagonists, which has come up recently. So hypertension is a very important treatable and modifiable risk factor for cardiovascular disease. So premature death and premature comorbidities can be prevented. Now, target blood pressure, we all know 130/80 is the target blood pressure. And this concept came after the sprint trial. The sprint trial, which you must read, Google out, what is this sprint trial? And that gave us idea that decreasing blood pressure from 130 to 120 systolic converts into means saving a lot of lives. So these are the summary of what all we do. So and we apart from lifestyle modification, which is important for every one of us, like weight reduction, less salt, control of obesity, exercise, we have to have combination drug therapy, which I told you. Always start with 2 drugs, not 1 drug. And endovascular renal denervation, which I have shown the picture, the first slide, has come up is a savior of problems, misery for us, like severe refractory hypertension. Renal denervation is a modality which can be offered to our patients. Now, the prevalence in India is quite, I told you that it's quite high. And this is a paper from Dr. Gupta from Jaipur, and he has done a lot of epidemiological study on hypertension, apart from other things. And you see that even the pre-hypertensives are maximum in the younger age. Another concept which has recently come, which I saw in Jack, was that systolic blood pressure variability is very, very important. Even if your office blood pressure is normal, you must have an idea of seeing the variability of blood pressure. And it is said that if you do MR magnetic resonance imaging in those patients, you can see that a lot of patients without having symptom will have smaller micro changes, micro bleeds, lacunar infarcts, so on and so forth. So blood pressure variability in a normal individual, in a normal blood pressure, can lead to serious problem like dementia and micro changes in the future. So we have to be very, very careful about the blood pressure variability. Something about blood pressure in India. I think that the most important causative factor for cardiovascular disease in our country is hypertension, apart from diabetes. So if you see that sympathetic overactivity is there in 2/3 of Indian population, this is known as adrenergic India. That's a very fascinating term which has been coined. Apart from blood pressure numbers, am I audible to everybody? Hello, hello, hello.
Yes,
Am
sir,
I
you are
audible to
audible,
you?
sir.
Sir, yes, sir, audible.
Okay. So, apart from the numerical value of controlling blood pressure, we have to see the quality of blood pressure, that what is the 24 hours blood pressure, what is the circadian rhythm. The morning blood pressure surge is very important in understanding the concept of uh, s- the cardiovascular events happening in the morning hours. So we have to be careful about that. And I told you BP variability is a very important issue. So now the concept of 24 hours BP monitoring and all those things have come up. And we have to be, as a clinician, you all have to be careful about not the numerical value of blood pressure, but also the circadian rhythm, 24 hours BP control, and BP variability. That's very important. Now, what is the recommendation? Everybody above 18 years or older should have blood pressure measured, and it should be there in the medical file, and they should be noted down that this was your blood pressure at this age. And it is recommended that you must check your blood pressure in both the arms, because anybody who has got difference of more than 15 millimeter of mercury in both the arms indicates a future cardiovascular risk. And so we have to be careful about it, that the blood pressure should be taken in both the arms. If the difference is more than 15 millimeter of mercury, uh, and it also gives you an opportunity to look for the pulse. Pulse should always be examined. Many people check blood pressure, but never check the pulse, because this gives you an idea of to determine the heart rate. Many people have tachycardia. That is another big problem. And such arrhythmias like atrial fibrillation can be picked up by just mere palpation. So this is a big issue in our country, and only more than around 10% or 12% or 13% people have controlled blood. Yes, we must know something about white coat hypertension. White coat hypertension is about 20 to 40%. They show a rise of the high blood pressure in the clinic, in the office, but they are normal at home. So we have to be aware about this thing also. And that is why it is said that home blood pressure monitoring is a better tool, and we must strengthen our society or people or patient who are coming to us, that you check your blood pressure at home also. So white coat hypertension is a important issue which all of us must remember. Now, something about the blood pressure measurement, very, very important. How do we sit? Where to measure the blood pressure? And this is very, very important. This is given in all the guidelines. Empty bladder, keep the leg uncrossed. Never cross your mm, lower limb, uh, because this causes rise of blood pressure. And don't talk in during the blood pressure measurement. The level of cuff should be at the level of arm, and support the arm at the heart level. So this is the classical way we should take the blood pressure. So we should train our staff nurses to do like this in a different room before they come to our chamber. This will give you a better blood pressure. So which is the best blood pressure way? So see, check the blood pressure. The automated office blood pressure is the best way to have the blood pressure check. Then comes the ambulatory BP monitoring, home BP monitoring, and manual office BP is the last. So that is very, very important. So now we are in an era where we must have an automated BP instrument, which should be there in our chambers. Now this is example of a dissection of aorta. So the young man who is hypertensive, chest pain, severe chest pain, ECG doesn't find anything. ECG is literally normal. You get this is a classical example of dissection of aorta, ascending aorta, and this we must keep in mind, that anybody coming with chest pain, we should always think beyond myocardial infarction. Some ECG we should never forget. Never say that ECG is slightly abnormal. This is a bad thing to use. Patient will ask you, what is the ECG, sir? How is the ECG? Say, slightly abnormal. Nothing like that. You have to give an affirmative answer and always correlate with the clinical features. So clinical correlation of ECG is a must. That is what the first lesson we should know, we should understand. This is a patient who came for cardiac evaluation, and it looks like ST elevation, but this is early depolarization syndrome. Early depolarization syndrome. This is a kind of benign condition, but this is not always benign. We must know that if these changes are present in inferior leads, 2, 3 AVF and V5, V6, this also heralds a future cardiovascular events or cardiac arrhythmia. So if repolarization, ERP or early repolarization is present in inferior leads as well as lateral leads, we have to be careful about it. This is not always benign. This is a ECG, classical ECG of atrial fibrillation. You cannot see P wave. RR intervals are variable. A fast heart rate, 80-year-old male, normal heart, normal LV function. So what is the choice of anticoagulation? Should we give aspirin or aspirin clopidogrel or oral quanticoagulant, or leave him alone because he's 80 years? The answer is oral anticoagulant. So this is very, very important to understand that anybody at this age with atrial fibrillation, we have to give oral anticoagulant, because anyway, and we have to remember that Chad's VAS score, each one of us should have Chad's VAS score in our chamber or wherever your study table is. This is example. This is the classical management of atrial fibrillation. ABC. A stands for anticoagulation, to avoid stroke. B stands for better symptomatic control. C stands for comorbidity and cardiovascular risk factor management. So this is very, very important to understand that in atrial fibrillation, cardiovascular risk factor management is very important apart from anticoagulation. And Chad's VAS score should always be remembered. This is very, very important. And then symptomatic control, rhythm control has come in a big way. Now people are aiming at rhythm control rather than rate control. So that we have to remember. Something about pill in the pocket approach. So if you have infrequent proximal paroxysmal atrial fibrillation, you give these two drugs which are available in our country, in Bihar, India, everywhere it's available. Flecainide and propafenone, these two drugs can be given stat, one dose. Like if you are using flecainide, then 4 tablets at a time, 50 milligrams in atrial fibrillation, and quite a good number of times, the rhythm will come to sinus. Now, coming to some concept of sudden cardiac death, which is a very important issue now, and you can see that people are just watching. Somebody has fallen and become unconscious. So, many people, younger people, have had cardiac arrest like this, and in our country, and they succumb to it. A singer like KK and so many people. And this is a example which I cite, and when I do a program on CPR, cardiopulmonary resuscitation, I keep showing these slides and how the incidence of heart attacks and cardiac arrest has increased in our country from 2015 to till now. And we will listen to.
Hi, I'm Shilpa Shetty Kundra. I'm here to broach a very important subject. I'm sure you are all aware of the seriousness of a cardiac arrest, where the heart just stops functioning. It's a life-threatening situation that can impact anyone. Life is so unpredictable, and no one knows when they may be the sufferer or just an onlooker of this scary situation. However, if you are trained in CPR and you come across someone having a cardiac arrest, you can actually save that life. Actually, we can all do that if we simply learn CPR. It's easy to learn, and just the fact that you can save someone's life cannot be better karma than that. So let us pledge to this cause to help contribute to the well-being of our nation and our people. Namaskar.
So it's very important because, time is extremely important. So I think all of you must be knowing CPR very well. And CPR is a technique which is very simple and we should learn because time is very important. Once the patient goes into, as long as patient is having electrical instability like VT or VF, you can save the patient. Start CPR, use AED, and you can save life. The technique should be known to everybody. This is a classical example of doing CPR, 100 to 120 per minute, 2 inches deep, uninterrupted. This is and full recoil, complete recoil. But that is a concept. And AED use is a must. Right now, and I'm in USA, I see everywhere, there is a AED kept, whether this is airport or a sports field or anywhere. So that is very, very important that AED use, because without AED, you will not be able to save many lives. These are some of the pictures in our hospital where we are very proactive in doing certain cardiac arrest programs. We have done in schools, we have got used our SDRF team, State Disaster Management Group team. And so we have to understand that CPR is a must. If you are doing bigger things like angioplasty and cath lab procedures, but if you are not knowing CPR, it will be a very sad affair. So now coming to a very important concept of how ECG can pick up a predictor of sudden cardiac death. We have to be very careful on these factors. Like somebody's ECG QRS duration more than 110 milliseconds. Are you able to listen to me clearly? Hello?
Yes, sir. Able to listen to you.
Yes, sir.
Then QRST angle more than 100. Left ventricular hypertrophy and T-wave inversions. They are the 4 things which are predictor of sudden cardiac death in 10-year follow-up. And there is a 3-fold rise of sudden cardiac death in this group with these findings in the ECG. So a simple ECG can give you so much of idea. That is what I wanted to convey to you all. This is narrow complex tachycardia and this is wide complex tachycardia. Narrow complex tachycardia generally are supraventricular, not always supraventricular on the left side. On the right side, you can see the wide complex tachycardia, generally ventricular tachycardia. So this is important to understand what is the difference between a wide complex tachycardia and narrow complex tachycardia. A wide complex tachycardia generally would be a ventricular tachycardia. Not always. It can be a supraventricular with aberration and things like that. So this is a classical example of ventricular tachycardia. And here the diagnostic picture. There are the various signs. But any hemodynamically unstable wide complex tachycardia, my message is cardiovert. Any wide complex tachycardia with follow-up blood pressure, patient going into shock, background of acute MI, chest pain, cardiovert. So that is the first, this is the message I want to give you. Another question is cardiac arrhythmia curable? Yes. They are curable sometimes, not with the drugs, but with various maneuvers like radiofrequency ablation, And you can see that AVNRT and AVRT and atrial fibrillation and even idiopathic ventricular tachycardia or ischemic ventricular tachycardia, they are curable by virtue of giving radio frequency ablation. You all can get a short note on radio frequency ablation, and you have to be knowing this much only. This is a classical example of conduction disorder of the heart. This is a complete heart block. And another ECG, interesting ECG of a life-threatening condition. This is hyperkalemia. When somebody is, comes to you in a dying condition, you have to be careful. If you have to use calcium immediately, because give IV calcium, patient will revert to normal sinus rhythm. So that's very important. Background of chronic renal failure or renal problem. Patient comes with this ECG in a shock-like state. Be ready with calcium gluconate in your clinic or wherever you are practicing, and giving 10 ml of calcium gluconate will revert the rhythm to sinus, and his life will be saved, and then you can go for further planning. So very, very important also. So you remember this ECG, extremely important. So, this patient of classical hyperkalemia, everything can be given: intravenous calcium chloride, intravenous glucose and insulin, nebulized with sympathomimetic, whatever you have. So these three drugs will be choice drug. And then intravenous magnesium sulfate, no, it is not. So everything can be given except magnesium. Coming to heart failure, which is an important topic these days, and you see number of heart failures increased because of two things: large number of ischemic heart disease which are not treated properly, large number of myocarditis which are not treated properly, and large number of hypertension which is not treated properly. So they are the common causes. And acute MI patients come to you late, after say 24 hours or 48 hours, and then the heart, the ejection fraction has already gone down to a very low level. So a lot of studies are there, and which recently, these drugs like ERNI and SGLT2 inhibitor has changed the paradigm of heart failure management. So ERNI should be started as early as possible, and the concept of why this is important, because if you leave heart failure like this, every episode of hospitalization leads to progressive decline of cardiac function. So that's extremely important. And they are the mighty four of heart failure management. We all must know. Maybe already you are knowing it, but then beta blocker, SGLT2 inhibitor, ACE inhibitor, oblique ERNI. So now ERNI has taken a higher this thing, and ERNI and SGLT2 inhibitor, beta blocker, and finally mineralocorticoid receptor antagonist. This has come in a big way, and I'll come to the point of a new molecule which has come, which is going to change the paradigm of management of heart failure. So this trial, all of us should know that empagliflozin, and the beauty is it starts acting very early, and it doesn't have any side effect like hypotension and all. So you have to be fearless. Use empagliflozin or dapagliflozin, any of the SGLT2 inhibitor, that would be helping the patient. Also, it lowers the risk of serious kidney events. That is very important, because I'll come to that point of cardiometabolic kidneys situation. The another new concept which has come is how to give these four drugs, mighty fours. See, earlier it used to be a conventional sequencing. one by one. But now we have to know on the right side, you see there's beta blocker plus SGLT inhibitor, then ERNI and MRA. These are, this is a new sequence. And, probably within a week or within a few days, we can give all 4 drugs to have the maximum therapeutic effect. And that is very important to know. All of us should know that 4 drugs should be sequenced fast. Not that, for a few weeks, you are waiting and then you should give drugs. So that's very important. So this is the concept, new heart failure concept, that guideline directed medical therapy, which should include SGLT2 inhibitor. And now another concept is, another thing we should remember, all should remember that iron deficiency, anemia, hypertension, sleep disorder, type 2 diabetes, atrial fibrillation, coronary artery disease, you should remember everything. We should investigate for everything. And sleep apnea is become, obstructive sleep apnea is a very important issue now with obesity. And so we must think about all those things. Now the concept of cardiorenal metabolic axis, we have to understand that the relationship of heart, kidney, and metabolic syndrome like diabetes and other things, and obesity is very important. So we have to, balance everything, and the risk factor, at the level of risk factor, we have to be very, very proactive, very, very proactive. When the chronic kidney disease starts, you have to understand that concept also. Diastolic dysfunction or heart failure with preserved ejection fraction, that is the stage where, we have to be very, very proactive and try to take care of all the risk factors which have taken, and then drugs are there now, especially the SGLT2 inhibitor, which are going to help. Finrenon is a new molecule which has come up recently to help us. And the clinical inertia should not be there. We have to be very, very smart, and that we should not say that, no, he looks stable, so we'll assess in a few months. No. And also people say that it's best in people with diabetes only. No. So we have to be very, very proactive and start acting fast from the beginning. I'll give you an example of a heart failure patient. This lady has heart failure and with a murmur at the apex mitral area. 70-year-old lady, and she had recent MI, and she presented late when LV function decreased. So the most important problem of acute coronary syndrome or acute myocardial infarction is that patients present to us late. And we have to spread the message in the society that, early stabilization is very important. So if you see acute MI, act fast. Do anything which is possible. And patient, despite evaluation, he had the heart failure continued, and so she underwent a device known as mitral clip, wherein the idea is to decrease the mitral incompetence degree. And then this was the first mitral clip done in our hospital, Medanta, and the clip, what clip will do is decrease the MR by clipping the cusp. So the severe MR will be converted into a mild MR. So you can see a severe MR will convert it into a mild MR. And clip, you can see the clip there. Clip is visible here. So one orifice of severe MR, one orifice causing severe MR will be converted into 2 orifices of small MR. That is the concept. So mitral clip is also is an important armamentarium. But all these are very, very costly. That is a problem. These are the guidelines which all of us should know. Surgical revascularization is a very important issue. Optimization of guideline medical therapy, transcatheter edge-to-edge repair, as mitra clip I told you, and something, there's some role of wireless monitoring of pulmonary artery pressure. So this is a picture which all of us know that this important thing is delay should not be there in acute, in reperfusion in acute MI, and this is the classical slide which all of us keep seeing, that primary angioplasty is the best answer, but if not available, then thrombolize the patient and ship the patient for wherever is the lab. Atherosclerosis starts very early. We have to start acting proactively. We have to tell our young boys and students that, even the 20-year-old boy will have atherosclerotic lesion. So we start proactively, diet, exercise, and if required, drugs. Rheumatic heart disease, a few words about rheumatic heart disease, not yet gone, very common. We keep seeing, and this is a preventable disease. And echo plays a very important role in diagnosing a rheumatic heart disease. We know all. I think we had several classes of on echocardiography, and we have seen that rheumatic heart disease can be picked up, early rheumatic heart disease, by echo. So echo plays a very important role, apart from Jones criteria, which you all must have read. So Jones criteria is now including echo findings also. So still, how among poor and underprivileged class, we have to be careful about it. Our job is not to only treat the richer class of people, but also those who are poor. And the penicillin prophylaxis, we know that it plays a very important role. And anybody, benzathine penicillin is the drug of choice. Less than 27 kg, 6 lakhs, more than 27 kg, 12 lakhs. And how long it should be given? If there are no carditis, for 5 years or until 18 years of age. Resolved carditis for 10 years or until 25 years of age. So that is very, very important to know how long to continue. This is a question is frequently asked. If the patient is sensitive to penicillin, then what to do? Erythromycin is another choice, or oral penicillin. Something about the CT coronary angiogram, and we are doing a triple rule out, which rules out coronary artery disease, pulmonary thromboembolism, and you can see that clearly. You can see. So CT coronary angiogram is another thing which has come up in a big way. And we have a facility in our hospital which is known as triple rule out, which rules out 3 diseases: coronary artery disease, pulmonary embolism, you can see here, and you can see dissection of aorta, very, very important. I told you, somebody who is hypertension, severely hypertensive, comes to you with severe chest pain, with literally normal ECG. Should definitely, you should ponder, can it be a dissection? And many dissections we have diagnosed and saved also, the mortality being very high, because those patients have to be sent to surgeon very fast. Intravascular lithotripsy is a new armamentarium which is available now. You can see this the bar which is revolving at 10,000 revolution per. And you can see that this bar is moving to and fro. You can see this is bar. Apart from angioplasty, newer things have come up. You can chisel out the calcium. It's very, very important. And then you can see that artery is flowing. Uh, Again, I'm coming back to a very important issue that hypertension is not a lifelong disease. It can be reversed by virtue of right changes in the habits. And thinking that doctors and hospitals are needed to keep the society healthy is a plain rubbish that was told by great man Macfarlane Burnett. And that is the truth, that if the society has to be kept healthy, doctors and hospitals are not the solution. Solution is the society, uh, kind of sensitizing the society, community as a whole. Uh, this is the classical concept which has come up in our country, the Kerala, this Tamil Nadu model of managing acute ST elevation MI. Hospital which have 24 hours PCI capability, they are there in the center, and then you have a spoke model. There you have a hospital which have got catheterization laboratory not functioning 24 hours, and C and D are the hospitals which are located within 30 minutes of transportation time. So this is the classical hub, spoke and hub model of managing ST elevation MI, which has been proposed by Tamil Nadu. And now something about pulmonary embolism, very important issue. S1 QT T3 in ECG, not always present. This is not very common to see this finding, but pulmonary embolism is a very important issue, common issue, which should always be kept in mind. And the mythology of PE is very interesting, that patients with pulmonary embolism are short of breath and have chest pain. This is not always true. So that we have to be cautious. This is again narrow complex tachycardia. It can be AV and RT, AV nodal reentrant tachycardia, or AV reentrant tachycardia because of pathway. So this is cardiac synchronization therapy in heart failure. When you have 3 leads, you can see that 1 lead is here. This is in atrium, right atrium. This is in right ventricle. And this thin lead is in one of the branch of coronary sinus, and that is veins over the left ventricular surface. So these 3 wires, and this is known as cardiac resynchronization therapy in heart failure. This is the transcatheter aortic valve replacement in case of aortic stenosis. This is now reality. Even we are doing in our hospital. So through the femoral artery, you go and put a aortic valve at the aortic. So this is a tower or transcatheter aortic valve replacement. This is a reality now in USA. This is done in large number of cases, and we have almost like 1 lakh cases every year like this in. So in our country also, this is a reality now. The large number of centers are doing it. In Patna, we are this thing, and see how nicely the valve is implanted, and patient doesn't undergo any surgery or anything like that. Patient goes home same day or next day. So that's very important. The reversible cardiomyopathy is one term which we should remember, that any tachycardia can lead to dilatation of the heart, and we have to keep that in mind. Hypertrophic cardiomyopathy should always be kept in mind. A 30-year-old male no cardiovascular risk factor, family history of sudden cardiac death, and you can see the ECG, LVH with STT changes, and ECG is very classical, but we have to see that there can be many causes of thick ventricle, and we have to rule out all those things. And those mimics should always be remembered: athletic heart, congenital heart disease, aortic stenosis, severe hypertension, and family history should be taken, physical examination, ECG, echo, and cardiac MRI. Cardiac MRI has given us a lot of insight into the problem. And you can rule out something like glycogen storage disease, cardiac amyloidosis, and all those things which mimic hypertrophic cardiomyopathy. So we should always concentrate on clinical finding and history rather than jumping on only echo finding. There can be several causes of, hypertrophy. Hypertrophic cardiomyopathy, apart from hypertrophic cardiomyopathy, amyloid disease, severe hypertension, Friedreich's ataxia, one condition was cardiac oxalosis, lysosomal storage disease. So at least we have to be proactive in ruling out amyloid. Amyloid is, if you think about amyloid, you will be able to diagnose amyloid. Something about broken heart syndrome or Takotsubo cardiomyopathy, which simulates acute coronary event, acute MI. And you can see this classical echo. This is a reversible kind of cardiomyopathy, which improves after management. And so I am not going to go in details of all these conditions. I've talked about hyperkalemia causing heart block, and treatment is IV calcium. Must keep IV calcium in your clinics. Now, coming to some preventive aspects of this thing. So, CKM syndrome or cardio kidney metabolic syndrome, this has come up in a big way. So, we have to remember that once the excessive dysfunctional adipose tissue is there, you have metabolic changes and you have chronic kidney disease, then subclinical cardiovascular disease, and then finally florid cardiovascular disease. So this is a very important terminology which has come up recently. We must be aware that it's a combination of CVD, metabolic disease, and chronic kidney disease. And last I told you about a few minutes back that finerenone is a new non-steroidal mineralocorticoid antagonist which has come up, and this is doing very well. And you can see that all spectrum of problem, like first heart failure episode or cardiovascular death, and new onset of heart failure, all these three, this molecule is coming. So this prevention of heart failure, this molecule has got 1A recommendation. So finerenone, although it is costly, but we are using it in our patients, and this has given us very good results. So now we are coming to the area of, in preventive cardiology or preventive cardiovascular death, we are precision medicine, and we are having precision public health targets also. And you can see that we have to be very, very careful in prevention now, and prevention is the answer of all these miseries. Million Heart Program 2027, and this is aiming at to impact by building healthy community, by decreasing tobacco use, decreasing physical inactivity, and decreasing particle pollution exposure. That is very, very important. And optimizing care of what? Improve appropriate aspirin anticoagulant use, improve blood pressure control, improve cholesterol management, improve smoking cessation, and cardiac rehabilitation is coming in a big way. So this is a very important kind of target for us. Pregnancy and postpartum with hypertension, we have to be careful. And behavioral health issue with use of tobacco, people with low incomes, we have to be focusing on all these areas. People who live in rural areas or other areas which are not accessible. So the future direction is prevention. I'm sure you would agree with me that future direction is, and this is a patient-centered preventive strategy and implementation of evidence-based therapy. That should be the goal. And we have to understand this, that metabolic dyslipidemia, heart failure prevention, BMI, obesity, blood glucose monitoring, social determinant of health. And then we have to consider all those things. And USCR is very important. Urine albumin creatinine ratio should always be included in evaluation of all those patients. Then only we can have a lot of preventive targets in our mind. So last few slides, 1 or 2 slides, I'll say that pessimistic see difficulty in every opportunity. The optimistic sees opportunity in every difficulty. That should be our goal. And what fits your busy schedule better, exercising 1 hour a day or being dead for 24 hours a day? That's very important message I want to convey. We are still improving. We'll be learning till the end of our career. Thank you all very much. So if you have any question, I think you can ask me.
Sir, heart failure is difficult to diagnose in the clinic and the setting, sir. So we had only one session on heart failure. But if in future, if it is possible for you to have,
Yes, we'll definitely have. You want that one more session on heart failure?
yes,
Definitely.
sir.
We'll have a very good session on heart failure. Coming 1 or 2 sessions, we'll have by Anupam Bhambani from AIMS Patna and Nishant Tripathi. These 2 guys, Nishant Tripathi, I'll request him to do it for you all. Is that okay?
Yes, sir, sure. At
And
your convenience, sir.
yes, and I'm very, very happy, very, very happy that you guys are showing so much interest. I am thankful to you all. I am thankful to API, thankful to 3 Dot Life. They have done a great job by helping us right from the beginning. You can imagine the kind of
Good
things
evening,
they.
sir. Can we have a session on the artificial intelligence in the health? Because how can we use artificial intelligence in our learning and
Surely we can have. Surely. Good. I'm noting down all these things. We can have artificial intelligence in cardiovascular medicine. Will that be okay?
thank
So
you, sir.
we will do it. We will do it. I'm jotting down. So we'll do it. So greetings from USA, where I'm staying these days in San Jose with my children. And this is the house of my daughter where I'm there. So I'm trying to, because nobody agreed to do the program this time. So I thought I'll do it myself. I hope you're not bored too much.
No, sir, it was interesting, sir. Many points and the newest, latest guidelines, were really helpful, sir. I took some screenshots as well.
Yeah. So thank you all. Uh, thank you all very much. And thank
Thank you,
you,
sir. Thank you.
PI. And thank you, Anand. And thank
Thank you,
you,
sir.
3
Thank you, sir.
Sciences.
Thank
Okay.
you, sir.
Bye-bye. Bye-bye.